Thank you very much, Frank. So before I start, how many of you have had coffee this morning? Just put your hands up. I won't be able to see the other sites, but I see them, so about half of you. If I remember, I'm going to take advantage of that later on in my talk. So even though Dr. Molnar mentioned that I'm going to be telling you about behavioral management, I'm actually going to do this at different levels, go into neurophysiology, neuroanatomy, and then try to link some of the things that we do to that, but hopefully in a way that's very understandable. So these are my disclosures. So I have done continuing medication kind of stuff in the past. I haven't done this for many years. Most of the products I worked on never made it to the market, so maybe I don't have much bias. So normally in a talk of behavioral management, these are the kind of things that I would be going through, and then it would become a very didactic, pedantic kind of presentation. I want to avoid doing that. I'm going to be focusing mainly on number 5, but focusing on the things around number 5. So the non-pharmacologic interventions, why maybe they might work, the kind of evidence-based results that we have out there, but hopefully in a way that's interesting. Not that it isn't interesting, but this will be kind of a trick here. I'll get to that right away. I did this presentation in a more advanced version of PowerPoint that they have at the hospital, so some of the slides aren't going to come out exactly as I wanted, but hopefully it won't miss any of what I'm intending. Anyways, my first slide, which gives away something, it's not supposed to move apart like that at the beginning. What I'm trying to illustrate there is that in terms of behavior, behavior is a response to some kind of a stimulus. So all of us do that. Dogs do that. When dogs see bunny rabbits, they get all excited and they want to chase them. We have the same kind of things inside of us. And so a lot of what I'm going to be going over today is about the sort of the intricacies of this at a very basic level. The difference as we become more advanced is that choice becomes more and more of a factor. Now, today I'm going to be talking mainly about people who have dementia, and as you know, as the dementia progresses, choice becomes less and less of a factor in them, and they show more of the immediate response to some kind of a stimulus that goes on around them. So to introduce sort of the neurophysiology, neuroanatomy bit, I'll use this slide that comes from Ledoux. He wrote a really excellent lay version of his research. It's 1996 that it was published, so it's a few years out of date in some areas, but the gist of it is more or less correct. So what I'm going to do is summarize his book in one slide. So basically, what this is here is that this guy is walking along in the forest. Oh, I shouldn't use the mouse because other sites might not see it. Guy's walking along in the forest and he sees something on the ground. Okay, so to us on this picture it looks like a snake. We have in our brain 2 basic pathways that respond to this kind of a stimulation. And before those 2 pathways break off, we see something, it goes to an area of the brain called the thalamus, which is the way station of the brain, sort of a train station. And from there, either you can get both of these happen at the same time. You get a very fast response, and you get a slow response, or what Ledoux refers to as the fast response is the low road, or a more primitive kind of response. This is the arrow that is dotted starting from visual thalamus, for those of you who are off-site. The thalamus right in the middle of the brain in this picture, and going to the amygdala. And what that does is that gives the immediate response. So in the case of this man, I'll call him Bill. Bill sees something on the ground, and right away he reacts to it as if it's a snake. And when you get that kind of reaction, the amygdala starts to get the body ready for some kind of response. And in this case, his heart rate goes up, his muscles start to tense, the sweat glands start producing perspiration, so that way he's all slippery in case something grabs onto him and he can get away. The high road, which is the other pathway, the blue one that continues back to the back of the brain, takes longer. And eventually what happens is Bill notices, oh, it's not a snake, it's actually just a stick, which isn't really illustrated on this. That takes a little bit longer. And you probably are aware of that in yourselves, that when something happens, you get frightened, and then as things become clear, you start to realize, oh, okay, it wasn't what I thought it was. And all of us have this system. And as we progress, I shouldn't say that, those who have dementia as they progress lose certain aspects of that system. Anyways, the way that Joseph Ledoux describes this is that it's better to mistake a stick for a snake than a snake for a stick. So in other words, we want to have that immediate response in us to protect us, because if we didn't, eons ago, we probably would have been eaten up by the saber-toothed tigers. So this is basically the same system illustrated in a different way. On the left hand of the slide, you have the stimuli that come in. So you can hear things, the auditory one, see things, the somatic. Those are actually newer on an evolutionary basis than smell. Smell actually is a chemical detection of things that go around in the environment. It's a very old response. We have that system in us, but that one goes directly to the amygdala. And there's more and more about smell that we're starting to discover these days, and the importance on how it affects behavior, but it's still a relatively unknown area. There's a lot more that's known about visual response. That's been very well studied, a little bit less about the auditory and the somatic, or the sensations. But basically what happens here, if you look at the bottom, the stimuli eventually go to the amygdala and you get responses. And these are known as the 4 Fs: fight, flight, and you've probably heard of that, the fight or flight response, food, and the other F, which is sex. And I won't use the term that normally is put in there. So basically, if you think about this, at a more primitive level, or at a time millions and millions of years ago, what was important to the animals that were going around was, can I eat it? Will it eat me? Can I mate with it? Will it mate with me? And that's what resulted in animals being able to survive in the environment and continue on. And we still have that. But with evolution, as it progressed on, there were additional layers that got added on to that. So one of the layers is the sensory and association cortex, a decision-making process which takes in those stimuli and decides, what am I going to do with it? And then the hippocampus, which is where context-dependent memories are stored. Context-dependent meaning that when you're in a certain environment that you have been in before, the memories of what have happened there come back to you, and you make decisions based on those memories. Now, as we all know that with the patients that we have, when they come in hospital, they're not as able, when they're very ill, to make appropriate decisions. So some of the things that affect them are delirium, for example. The area that I'm going to be talking about today is dementia, developmental delay, and other neurologic disorders. I'm not going to go over lists of things, just that's sort of the overall context that I'm talking about. Psychiatric disorders also affect these decision-making areas. So with the patients that we have in hospital, with these kind of problems, they're less able to use the choices that we're able to use, and they're more likely to have a more primitive response to whatever goes on around them. Now, where did we learn this? This is actually relatively new kind of information. Philosophers have talked about these kind of things for years, but without really being able to look into the brain. So to get to this, how many of you have heard of Phineas Gage? So few of you. Okay, so I'm going to be showing you a video of Phineas Gage, and those of you who've never heard of Phineas Gage before, I'm sure after the video you'll remember him. Throughout history of psychology, psychiatry, and many other medical areas, there are certain people that have taught us a lot about how the body works. So this is one of them. I'm just going to close down, there's a keyboard, okay, to shut down this and get the video. Actually, just before I'm going to do that, make sure that that was the next slide. Yeah. Okay, so if you're interested in seeing that video again in the future, all you have to do is put Phineas Gage into YouTube, and it'll be one of the first ones that pop up. It was from a PBS show about emotional dysregulation, so I extracted some of the information there. So anyways, Phineas Gage, he was a real person. After that, he did live for many years. He demonstrated the thing that went through his brain at fairs. He was never able to work as a foreman again. He became a lot more like James in that video, who didn't have quite as good restraint on his own emotions as Gage did before this happened. And then the second picture there is what Gage looks like now. So anyway, there's a saying there that after the accident, Gage was no longer Gage, and we see that's the case these days as well. Okay, so that's sort of a summary of the system in the brain that regulates our behavior, also our emotions and things like that. And that's the system that the regulation of it doesn't work as well in dementia. And in fact, the amygdala, the part of the brain where those 4 F's come from, is highly resistant to any kind of trauma or insult against it. So you'll see this in the patients that you have in the hospital with dementia, that a previously sweet old lady will be swearing, using swear words, making inappropriate comments. The men that you have that try to touch the care staff in places that you wouldn't want them to touch. And that probably all comes from some of the vestiges of this system that we keep under control. Now, one thing that's very interesting is that despite the fact that we're seeing more of those kind of things, when medication trials are done in dementia to try to reduce these behaviors that we don't want to see, primarily agitation, the interesting thing about the studies is that the effect of placebo in them. So you would think that if this system isn't working, then a placebo wouldn't be very effective. But obviously it does, and you can see in one of them happens to be one of the larger ones, Didane on the right-hand side. 60% of the patients in there responded to placebo. So what was placebo in these studies? Well, placebo was a research assistant going to meet with these people who had dementia, talking to them, doing rating scales on a regular basis, trying to evaluate if any changes were happening, engaging them on a regular basis. And that probably was one of the things that helped. This is one thing that in long-term care facilities, unfortunately, the staff, there aren't enough of them to be able to do that. And that's one of the areas where we would see these kind of problems happen very often. Or the other situation that at home, the caregiver, the spouse or the daughter, would be too exhausted to be able to be very calm in these kind of situations. It's a lot easier for a research assistant who goes in and then comes out. So anyways, that worked very well. So knowing that, many studies have been done looking at, well, what kind of non-drug approaches can we use to try to help people that show these kind of behaviors? So this brings me to lemons. Now I want you to do something, and this is relevant to my talk, okay? I want you to think about yourselves going into a grocery store, one of the ones like Farm Boy that has all the fruits and vegetables at the entrance, and usually they have some of these fruit that are cut up for you to look at, sometimes to taste. So you come up to these lemons, they look like this. They're the nice big juicy lemons, and there's a knife there. And this time you get to cut the lemon. So you pick up the knife and you're cutting through the lemon as they usually do, just like oranges. They let off this spray, and the spray has a very lemony smell, and you smell it going into your nose, and juice has come out, and some of the juice gets onto your fingers. So you lick your fingers and you get that lemon in your mouth. And what happens as you're doing that? What's the response? You get saliva. How many of you, just thinking about that, are starting to have some saliva running in your mouth? Okay, a few of you. And the important thing there is that you're getting a physical response to something that's just going on in your head. You don't have a lemon in front of you. You don't have the spray in front of you, but yet that's enough to try to create those things. Many years ago, Pavlov is probably a more familiar name than Phineas Gage. Pavlov did this with dogs, and to the point that when he sounded a bell, so an auditory stimulus, they were able to produce saliva. So we know that things that have nothing even to do with something physical that you can hold on to results in changes, or also things that are going on in our mind that we can't even look at. And as my son says about Pavlov, Pavlov rings a bell. Okay, so although we do these kind of studies in people with dementia using medications, there are far more types of behavioral problems in dementia that don't really respond to any medications at all. And these tend to be the more problematic ones. And if you look at that, these are probably things that you've also had to deal with on inpatient units here, or in nursing homes if you come from there, or even at home. And they're very difficult. And I was thinking I would tell a few stories about some of them, but that will take up too much time. I like stories. I have a few stories actually I'm going to tell. So these are the kind of behaviors that I would go into a long-term facility and try to help the staff with. But actually the people that help the staff a lot more are the 16 nurses that I work with. They go in, they spend a lot of time, they look at these behaviors, they look at how staff interact with the patients, and they try to come up with ways to help them. So I'll talk a little bit about that now. So first of all, here's the case of A. A is 87. She's lying calmly in bed, and she's approached by staff for AM care. And when the staff help remove her blanket, she screams, hits, kicks, scratches, spits. Probably a very common kind of thing for those of you that work with these people. She's injured many staff, and when staff are assigned to, or know that they're going to be assigned to her in this situation, they call in sick. Very difficult kind of situation, and not a good thing certainly for staff or for other patients, because if staff get injured, they're not around, and there's less and less of them around. So I won't go through the details of how we work this out, just to say that this is an example of the kind of things that have been studied. And one of the ways of looking at doing something for these people is looking at what's going on in the environment that might be making a change. So don't think about A now, because all of these things wouldn't necessarily be appropriate for A. Suffice it to say that there are many studies that are being done in these non-pharmacologic areas. The ones that I've put in bold on there are ones that have better evidence that they actually work. So they've been repeated more than once. It's been shown in these studies that while you're delivering this kind of a treatment, that you're getting reduction in the problematic behavior. And the one in red is the one that when you stop the treatment, the response continues on. Obviously, the difference about psychoeducation, basically that's a fancy way of saying education, is that that's being delivered to the healthcare staff. Most of the other ones are things that you would do with people. You'll also notice there in the first box, sensory deprivation or deficits, aromatherapy is mentioned. So there are a few studies that have been delivered in ways equivalent to the way that we do randomized controlled studies involving medications, but in this case it was with smell. So obviously it's a lot harder to do randomization because it's immediately obvious where the smell is and where the smell isn't. But what you do in those situations is that you count the number of times that there are behavioral outbursts of the patients who are in these studies who are at a cognitive level that one would hope that smelling and not smelling might not be as much of a factor. But anyway, so aromatherapy did work. And if you remember, that's one of those stimuli I was talking about, the olfactory ones, goes directly to the amygdala, so we even can bypass the thalamus and still get a response. Who doesn't know what snoozlin is, the first of those bold things? Okay, so there are a few that don't. Snoozlin is it's actually developed in the Netherlands, which is why it has looks different than English. This is a process where either there's a special room or a special cart with instrumentation on it that delivers soothing music. There are fiber optic cables to have lights that flash. And this isn't bright lights, these are very gentle lights. There's a projector that shows images. And what's found is that agitated people with dementia calm down in this situation, and when the machine is turned off, often the agitation comes back. So obviously not a terribly useful thing if you have a whole ward, but if you deliver this in situations where you know that agitation is more common, such as when these people are being bathed, that would be the kind of area where snoozlin might be very useful. You can have the soothing music, the lights in the background, things being projected, and hopefully easier to give a bath to someone who has a dementia. So similar ideas to the other things. The music taps into the auditory. Snoozlin is auditory, it's visual. But certainly the most important part is actually teaching staff, and I'll get into that a little bit later. So here's a case of B. B is bedbound, incontinent of urine and feces, is edentulous, and I was asked at the beginning what edentulous means, has no teeth, and only takes a liquid diet, unable to communicate with caregivers, requires total assistance for all activities, does smile at the sight of others, often screams at night and does not easily go back to sleep. And the caregivers in this situation, they're exhausted and stressed, and the other people living with B complain because they can't sleep because of all the screaming. So let's say someone is, a physician is called about B. What do you imagine would be the suggestion? I don't want you to think about what's the right thing to do. I want you to think about what you think is usually suggested in this case. Okay, Frank says Haldol. Any other thoughts? And I know off-site you can't really participate in this, but I presume the same ideas are going through your head. What else? What do you think, even if it's something you would never do yourself, what do you think would be suggested? Is that what you think a usual physician would do? I would say, is this person hungry? That's not usually what they do. They would prescribe some kind of drug, right? Now, if I told you that B is actually 2 months old, okay? She's bedbound, she's incontinent of urine and feces, she doesn't have teeth and has a liquid diet, okay? Unable to communicate other than by the social smile, requires total assistance, often screams at night, and the mother and father are really exhausted and they have trouble going to work. So is Haldol the right answer now, Frank?
Just in the milk.
In the milk, he says. Okay, Haldol in the milk. And actually, this sort of takes an aside. Mother's milk also had been studied many years ago to look at how many benzodiazepine equivalents it had in it. And it has sort of, a standard feed has about 0.02 milligrams of Valium equivalent in it. So maybe there is some kind of truth of drug in milk, but this is a natural kind of drug. So go back to case of A. We talked about her earlier. So what if A, it becomes C, and C is 23? And C is lying, let's call her Christine, is lying in bed at home and approached by intruders. And she screams, kicks, hits, scratches, and spits. That's a normal response. Okay, you wouldn't expect her to happily let the intruders take their sheets off and do whatever the intruders were going to do. Maybe one of the 4 Fs there. So this is a natural response. So in fact, the difficult behavior of case A was probably normal behavior. The problem is that that normal behavior is causing injury to other people. So we see it as an inappropriate response, but it actually is an appropriate response. So the thing is that what we're trying to do with these people is we're trying to take what is actually a normal response and changing it into an abnormal response, which is probably one of the reasons why it's so hard to...
Code stroke emergency, code VC,
So that's an example of an auditory stimulation that's getting some people's muscles to be all tense. Their heart rate goes up, they're breathing quicker, and they're running somewhere. A primitive response. I won't say anything more from there. Okay. So, one way is looking at the environment. Another way that we look at these kind of behaviors is try to see, is the fact that they're having dementia and the dementia is progressing a factor. So, this is a chart that shows a deterioration in people's abilities to function. Using the MMSE, which is usually something that we're doing less and less of these days, but in this particular study, which was done in 97, 98, that's what they used. And actually, if you look at that, if you go from the top and go down, you can also see that this is childhood development. They usually learn to eat before they're able to walk, before they start to, I don't know, some kids never dispose of litter until they move out of home on their own. So that might not be the right order. But anyways, here's loss of functional ability as time goes on. And take one example. The arrow should have gone up to dressing. At some point in the deterioration of dementia, the dressing, which originally was very easy to do and they've been doing since they were 3 or 4 years old, they lose the ability, and just that can make them extremely frustrated and agitated. So another thing that we also look at is that, are we asking these people to do something that they normally would be able to do if they were cognitively intact, but because of their deterioration, it becomes too much of a stress. So as an example of that, I'll bring back the coffee. So we'll pretend that the length of my presentation is sort of a developmental kind of progression. So you had coffee before you came in. Some of you are drinking coffee now or drinking tea. So when you came in, you were alert, you were ready for this presentation, but the coffee was having its effect. It was starting to produce more urine than you would normally have, and that's slowly building up in your bladders. Okay? So as this presentation goes on, your bladders are filling. Some of you might have even gone to Starbucks 2 hours ago before you came, so you have the effect of that coffee. And even though you want your sentient beings, you're using your brains, you're rational, you always make good decisions, you know what you're doing, as your bladder fills with urine, eventually other things become more important, to the point that your life will depend on whether or not you get to that washroom in time to empty your bladder. And it doesn't matter what else is going on, if there's a stroke code, if your cell phone is buzzing, whatever, you have to get to that bathroom and beware the people that are in your way. So that's sort of the same kind of idea. Early on in the presentation, whatever was in your bladder didn't matter, but at a certain point it became too much to handle and you could become aggressive and agitated. So this is what we're looking at in these people as they're deteriorating. So we try to evaluate that. Another thing we also look at is knowing that placebo is effective and some of those kind of behavioral interactions. We also look at, is it possible that they might be able to learn to do things differently, to associate certain things going on in the environment with change and behavior. It's very complex to describe how this works out. A lot of it is based on looking at what's happening now. Are there any particular things that people are doing that are triggering the behavior? Can we change that? Can we add something else instead that we can use to change the way the behavior is progressing? Suffice it to say that even though it's amazing to think that someone, as they have a dementia, might be able to learn something, we do find that behavioral therapy and cognitive kind of things can also work. So that's part of the assessment. We're looking basically at what's going on in the environment, what is the progression of the dementia doing to their ability to withstand the environment, and finally, is there anything that we can do to make changes that might trigger more appropriate responses? That's the first thing that should be done. Unfortunately, a lot of the time that isn't done, and people quickly jump to using medications. So I'm going to talk very briefly about how we might conceptualize that, because most of the studies involving medications in dementia haven't turned out to be all that effective, despite the frequency that they're used at. But basically, if non-pharmacologic approaches don't work, and we're not dealing with agitation, which is about the only situation in dementia where we have randomized controlled studies that show some kind of effectiveness, we go through this kind of process called I'm going to call this, and some researchers call this, neurobehavioral metaphors. We look for patterns that resemble a psychiatric illness, so restlessness, hand-wringing, pressured pacing, fidgeting might be like an anxiety. Or we look for things that look like sadness or withdrawn, so a depression kind of metaphor. Or bizarre behavior that might suggest something like psychosis, or overly boisterous, etc., that might suggest something like mania. So we look for these things, and if our other maneuvers haven't worked and we don't have any other bright ideas, we try to see if a medication that we might use in this area in psychiatry might have some effect. And sometimes it does, and when it does, we don't know, is it a placebo effect? We have no idea. In fact, most medications in the market in all areas of medicine, most of the time what you are getting is the placebo effect rather than the specific effect of the medication. Okay, so this is working slightly better than the first one. So I've been talking about the patient or the client or the customer, whatever you want to call them. We can turn this around and look at ourselves as well, because we have these behaviors and we have responses in stressful situations. So I did allude to that earlier. So we go through all this process too of responding to having an immediate response to a stimulation, and then maybe later on our cognitive processes kick in if appropriate. We have the same stuff going on in the brain, but hopefully we don't have a dementia, but we do have stress in our life. We have personal problems going on. Some, unfortunately, have substance use, and all of this has an effect on our abilities to make rational decisions about what we're doing, modulating our behaviors, and maybe block out what we have learned from similar situations in the past. And then what that tends to do when we're not able to think as clearly is that we tend to use what are known as cognitive distortions. This is from cognitive behavioral therapy. We use black or white thinking. We can't look at nuances to help us make decisions. We tend to assume that the bad thing that's going on is just affecting us all the time and nothing is good. We tend to dwell on the negatives. And this would be when we're under stress. So if you look at that list, it probably none of this is new to anybody when you think about either yourself or you think about friends or family when they're under stress and how they respond to things going on around them. And so commonly people might say, oh, they should just snap out of it, or they come up with very simple solutions. So part of the training that we also do is that in long-term care facilities, we help staff deal with these kind of problems. And there's a lot of education goes on to show them different approaches to situations that they find very difficult to deal with. A lot of this also comes in interactions I or the staff that I work with, my nurses, have with the long-term care staff to help them think through what's going on around them in general. Sometimes it's presentations like this, sometimes it's just dealing with a particular problem. Quite often it will be the difficult family, and we can't stand when they come in. So it's not only the patients or the clients in the homes that we help them with, but also the external caregivers that come in and get snapshots of what's going on, and then assuming that it's always that lousy and treating the staff as if they don't know anything at all. So all of that is very stressful. So some of the things that you could do is ignore the behavior, look at it in a different way, educate caregivers to do this. So one example here, take the second one, accusing caregiver of stealing. So the patient can't find something in the room, say their underwear, or my daughter has been stealing my underwear again. And to try to teach them, okay, this is because they have memory problems, the dementia they have is causing brain damage in that particular area of the brain. I mean, I'm really simplifying things now, but just to try to get the general gist of what we try to do with caregivers so that they can step back, look at the situation in a different way. Unfortunately, there's some people that can't do that. There's just too much going on, either in their life or learned from their background that they're able to do this, but we try our best anyways. Another thing that can be done with staff, and this can work quite well, is a process called stress inoculation. Very easy when you think about it, but people have to learn how to do this. It's basically, don't walk in that room expecting that this time I hope things will be better. So walk in that room preparing yourself for the worst. So the idea comes from being inoculated with something against a virus. So either you're doing the live or the dead virus is sticking in. So the bad thing is going into the body, and the body is preparing its response for when the real thing comes along. So same thing here with people, preparing them for the worst, and then helping them develop a way to talk through the mean things that they're being told or the attempts at grabbing at them. And if things going very well, that they can find some way of rewarding themselves. And as I mentioned earlier, we do behavioral management with staff, primarily the psychoeducation. I don't know if spraying stuff around in a nursing home affects the behavior of the staff. It might, just not something that's used. Music is often used by people on staff to help them through their day. So this is the end of the presentation. I have a video now that sort of illustrates this, and there are two people in it. One is a person who has an early dementia, and the other one is his son. It's in Greek, but they're subtitled, so you'll be able to understand it. What I want you to focus more on is the son, and think about what the son is doing in the context of what I've been talking about up to now with respect to behaviors and not being able to stand back and look at what's